Good day, everyone. My name is Ginger Davis. I am an adult living rare. I was the classic 2 out of 5 children inherit sickle cell disease and was fortunate enough to be diagnosed at the age of 2, where my brother Mark Anthony died at 18 months of age while my mother was 6 months pregnant with me and was unfortunately diagnosed posthumously. Uh, I think the first time I spoke up as an advocate, I was 3 years old, and at 8, decided to become an advocate for my brother, whom I always imagined we would be thick as thieves in this thing, understanding what each other was going through. I am the president of the Sickle Cell Thalassemia Patients Network, started as an adult support group for adults living with sickle cell and thalassemia, also known as Cooley's anemia. And 36 years ago, I inherited this legacy organization 3 years ago and immediately set our attention to expanding our organization and its services, education, advocacy, care coordination, referral to services throughout our state, because we knew that in counties upstate and even Long Island or in Staten Island, like we call the redheaded stepchild, did not have support services and barely any educated practitioners to take care of our population. And so we were able to do that through creating affiliates and chapters with advocates in different counties who wanted to do something. We reached out to them and helped them either start an organization, which became a chapter, and we serve as fiscal sponsors, or those that were incorporated and were seeking tax exemption became affiliates. And I guess by the end of the first year going into the second, we had brought on international affiliates in Belize, Uganda, and Uganda. So we are definitely growing internationally, knowing the need. And if we're going to be talking about diversity, one of the things, one of my soapboxes that I stand on in terms of diversity, sickle cell is characterized as a Black disease, and it is not. Yes, Africa is the most predominant population and people of African descent in America, but we're not the only ones. Mediterranean, Middle Eastern, Southeast Asian. Today's the first time that I've heard Southeast Asia mentioned. In Cambodia, Laos, Vietnam has sickle cell, has thalassemia. You never hear about that spoken of. India is the second largest population outside of Africa, and everywhere else in between, Central and South America, the Caribbean. In the US, sickle cell had come by migration prior to transatlantic slave, but mostly from that, and the same in Canada, and if we really want to talk about diversity, we have to take the Black face off and show the faces of the other ethnicities and nationalities that are impacted by sickle cell trait and disease. And when we talk about race, I'm going to encourage the conversation to change from races to one race, human race. There are nationalities, there are ethnicities that are impacted. This is a global disease. And to coin a phrase from Dr. Anna Wuspel, who is the director of medical affairs for Novo Nordisk, he says sickle cell is the least rare disease, and it is correct. It is the most prevalent inherited disorder in the world and the least supported, and particularly because of the perception of it being Black. We want to see the other faces, and this has given us the opportunity to do that. When you talk about inclusion, everything can't just be in English. Second is the second most populous Spanish is the second most populous conversation or language in this country, and we can barely find any literature in Spanish. If we don't create it, it doesn't exist. And now we need Hindi, and we need Farsi and Creole and French and everything else to represent the world population that is impacted by this disease. When we talk about diversity, equity, and inclusion, how do we have any of that without access? In 2021, 6 members of our Gambian affiliate died between March and August because they didn't have access to comprehensive care. 5 of the 6 were under the age of 30. died from complications that were treatable, that we have access to have insurance in the first place. So they couldn't afford to keep paying out of pocket for both treatment and medications. And this is happening everywhere else. I'm really happy to see that India's government is creating access and making such moves in a lot of ways. It's a little better than what's happening here in the US. When we talk about people in the Midwest, or the Northwest who don't have access, and telling us stories about how when they show up to the emergency room for treatment, they're being shown the door, escorted out by police saying, you're just here for drugs. This is our blood, and it impacts every organ and every organ system. We have end organ damage because of the severe anemia and because of ischemic damage from the sickling. And the pain is incredible. Healthy people could never know, unless you got hit by a vehicle, and broke almost every bone in your body, to understand the intensity of pain that we're feeling from as early as 5 months through the rest of your life. And we have a new term saying sickling is not seeking. Yes, we're coming in, and yes, we need pain management, but pain sometimes is an indication of some other complication that's happening. And instead of drawing a negative perception of someone based just on their diagnosis, hear a person out and listen to exactly what the person is saying. I've gone into pediatrics even where children were being put on ridiculous doses of narcotics, and they were saying this is not helping because they were giving medication for visceral pain when the patient was actually feeling neuropathic pain. And I'm like, change the medication. That's a simple thing, just listening to what the person has to say. Most of the time in dealing with our treatment is just listening, and what we have access to here. There are 3 new medications since 2017, and all I ever hear is about hydroxyurea. I know professionals think that's a standard of care, but it became that way because you've had 25 years to prescribe this medication and view how it works. And what we're not seeing is diversity and inclusion of these new medications into our care protocols. When I have a doctor saying, yes, I prescribe this to my patients, but when she reports on how many of her patients are actually on this medication, it's 3 on one, 4 on the other, 2 on one. Out of how many patients that you have that you're seeing? It's not equitable to deny a person a choice. And then with the clinical trials, a lot of the barrier is language, imagery. It's not representative of all of the people who are impacted. And, I've gone into hospital and see clinical coordinators sitting in their office expecting just the doctor to tell the patient, oh, we have a clinical trial here, or there are clinical trials going on. They're dealing with the patient and the issue at hand. I tell clinical trial coordinators, you should be out there in the waiting area talking to patients about this and giving them literature. And as an organization, we try our very best in many ways, social media, through our support groups, going into the hospitals, doing virtual support groups to say, this is available. You should talk to your doctor and ask them more information. And if he or she is not willing to help you with it, we connect them directly with the companies. So when it comes to DEIA, the act to have diversity, equity, inclusion, we need to have access. And that's something we're hoping that would kind of, take root and to grow in order for right here in the US as an example, and then to help facilitate this access everywhere else in the world.